Today on Keynote,
We're very much in the spirit of let's rising tide lift all industry boats, not like my vendor machine will beat your vendor machine, but we need the country to succeed.
my name is Bill Russell. I'm a former CIO for a 16 hospital system and creator of This Week Health, where we are dedicated to transforming healthcare one connection at a time. Our Keynote show is designed to share conference level value with you every week. Now, let's jump right into the episode. All right, it's Keynote. Today we're joined by Aneesh Chopra, former president of CareJourney, now chief strategy officer at Arcadia. Aneesh, always great to catch up with you.
And same with you, my friend.
I'm going to reminisce a little bit here. So we both had a vision for data-driven healthcare transformation. I remember that's our first meeting, and this goes back a ways. This probably goes back to like 2013, 2012, somewhere around there?
Very much, yes. And it was consumer led. Remember, we were very big into the idea of consumers would have a big voice in this, but keep going.
Yeah, and so that's what we connected on. And I was like, look, data can transform healthcare. And you're like, yes, it can. And we're going back and forth and we're creating a cheering crowd together. But here we are. We're a decade later, a little over a decade later. I want to touch base. I guess I came in from outside the industry. This has moved a lot slower than I could have even imagined. I thought, oh my gosh, we have all the tools, the technologies there. And quite frankly, even over the last 2 years, we had the advent of a whole new set of tools. Like we should be jamming at this point.
Yes.
Are we jamming or is this just the pace things move?
Let's describe the good, the bad, and the ugly. Let's start with the good. You can't have data driven without data supply. And the adoption of electronic health records that are certified is now ubiquitous across hospitals and overwhelmingly amongst physician groups. So we went from manila folders and maybe some practice management software to certified data ostensibly mapped to an open data model. And we'll talk about the FHIR API. So the good is a very clear win in terms of you can't have data driven without data. The bad is we're not as data driven as we should be, which is that to the extent that we have emphasized over the last decade supply side regulation, there's a little bit of a if you build it, will they come mentality. Did app developers come and make use of the data that we made public? Or did we find ourselves focused on more of a compliance? Did we have to do it? What did we do? That question, Bill, gets a little bit beyond technology, has a lot more to do with economics and incentives. And so if I'm in fee-for-service medicine, it's barely an incentive. If anything, it's a productivity, deflationary productivity, essentially. In other words, it doesn't give you the return if an hour spent reading 50 CCDs on a patient that have now been made available to me versus the 8-minute, 12-minute visit I have to understand the problem and to address the problem. I can't really blame the medical community for not using, quote unquote, the data because it was designed for the supply side to demonstrate they can produce it. It wasn't really optimized for the consumption and use. Now, I assumed the market would have solved for that. I'll go back to that in a minute.
This is going to be too strong of a statement, but I'm disappointed in the consumer. The consumer didn't show up to this game. Like we expected them to go, yes, I'm going to get my data, but they didn't show.
Yet, I want to come back to the yet part because ONC just did a pretty powerful report on patients with cancer. Newly diagnosed patients with cancer, 93% surveyed learned online of their diagnosis, meaning they logged into the portal to extract the data. But, and I'm going by memory, 6% used an application to help them interpret it, meaning they learned of it, open notes, but they picked up the phone and called and said, I want to talk, for any family member, what would you do? Call the doctor's office. What does this mean? What do I do? How do we deal with it? And so the market of applications that would naturally help guide me through it, that hasn't quite happened. And I think the ugly, to get metaphorical or metaphysical or philosophical, the use cases that work, Bill, are the use cases that have a clear economic return, risk adjustment, HEDIS quality gap closure, and those are payer-provider use cases. That has distorted data-driven because what does that mean? We probably have a much more accurate picture of the health of a population in a Medicare Advantage plan because every incentive is to accurately reflect the population's clinical needs. That's the economic incentive. But relative to the underdiagnosed fee-for-service system that doesn't even know what you have, doesn't record your ongoing clinical conditions, it looks like you see this sort of upcoding dynamic. And MedPAC is called, this is a $70 billion gap in terms of the use of data where there's economic incentive in MA relative to the lack of the use of data in fee-for-service. And I look at that ugly. Some would look at that and say that's a distortion in the market. It's an economic highest and best use of the data today. And what I think will happen in the not too distant future, especially with the advent of LLMs in our pocket, we may see a leveling effect where there'll be more regular and routine use of data interpretation services because it'll be much more accessible and democratized. You don't have to have a huge IT, which you can justify doing in risk adjustment and HEDIS. If it's lower cost to interpret the data, more people will use it. And I think that will create a culture where this data-driven will be the foundation of what should the right protocol be for GLP-1s. Should you do bariatric surgery consult first? Should you try nutrition counseling? Should you do GLPs with nutrition counseling? What combination of interventions can help someone with obesity manage their overall health? That kind of data-driven learning health system, I see it. I see it. I want to bring it to life, Bill. I'm going to dedicate a good chunk of my time to that future. But at the moment, it hasn't lived up to the hype, to your point. Good, bad, and ugly.
Good, bad, and ugly. It's interesting to me as we look at we now have a new set of tools. And I remember back in the day, one of the things that we heard was, what's the patient going to do with the data? If we gave it to them, what are they going to do?
I know.
And I was joking with an emergency physician who happens to be on my advisory board. I said, all right, I'm going to get on one of these tools. I didn't tell him which one. Claude, ChatGPT, doesn't really matter. Right. You start giving me stuff, I'm going to respond to you. And I started responding to him. And I'm like, okay, how close is it? He goes, that's really good. That's really good. I know, I understand the limitations of it, and I understand it can hallucinate and whatnot, but we're closer now than ever that I can take my data, put it into a tool like that, and start interrogating it and saying, what does this cancer diagnosis mean for me?
And literally in my inbox this morning on the day we're taping, a brand new paper preprint, the title I'll read, Superhuman Performance of a Large Language Model on the Reasoning Tasks of a Physician. This is the O1 model. You look at the possibilities and you see where this movie is going. And this is how far we've come without even training on health data. This is training on the internet, and we're getting to be this good. Imagine as we unlock the health data to understand protocols for which treatment options are best for me, given my circumstance, and patients like me in the community. Man, talk about reducing the variation in clinical care delivery. If you look at every one of the papers in LLMs, what gives me so much excitement at this moment in time is they lift up the bottom performers, right? So the variation is, hey, I've seen a lot of these. If your ER doc is amongst the best who's triaged it, like Halamka, who we both love, is like the global expert on mushroom-related illness, right? You want Halamka-style triaging on mushrooms in every ER in the country. And this is now feasible if we could see where these tools are going to get there. Now, there's also a little bit of a downside, which is that if Halamka himself were to use some of these tools, the BCG paper with Harvard Business School said the best performers sometimes mistakenly dumb down to the recommendation that comes out of the LLM, and they under-rely on their own expertise. So while there's a lifting at the bottom, that's a clear win. There's a worry about the super awesome might downgrade to just like default Cass Sunstein nudge style.
You read that document. Do you really think John Halamka is going to read it and go, yeah, I'm going to agree with the LLM? No, he's not.
And he's superhuman, so we love John. But in terms of the broad statement, if you're busy and you're trying to get through your day and there's a decision support tool that's helping you make a differential diagnosis, isn't it human nature to accept and move on and get to the next assignment? I don't know. It's a challenge. This is where this whole cultural change, liability, can I hold the LLM liable if it nudged me down the wrong path, or am I ultimately responsible for double checking all the math and the work? And if so, where's the productivity gain?
Right.
It's fascinating.
Talking to CIOs, there's a handful of things that are pretty interesting to me. One is we talk about transparency of these LLM models, and that whole concept that you just rattled off, hey, I'm going to check its work. We're not going to check its work. We're moving too fast in the care system to check its work. What does transparency actually mean in a large language model? And do we have the resources to really check those things? Now, I know Duke's spending a lot of time, and some others are spending a lot of time on this. And there's value in it because we're talking about LLMs. There's a whole another set of tools that are AI related tools that we do want to know what the math is. We saw this with sepsis and some other models that came out that were not vetted. One of the things that's interesting, I'd love to hear your thoughts on this, is we took a path. When you and I first met, I was taking a path of we've got to build these tools, we've got to build this stuff. And I feel like I was building this building and all these people were saying, somebody else is going to build it for us. I don't know what you're doing all that work for. Somebody else is going to build it for us. And recently we had an AI roundtable, 14 CIOs at the table, and I was asking them about the implementation of AI. And they said, first of all, Epic just rolled out 100 tools. I don't have to know AI at all. I just have to configure it and then fine tune it and then roll it out. And I said, how prevalent is that? I said, I got it from Epic. I got it from my imaging provider. I get it from ServiceNow. They're all dropping AI into their tools. And they're like, I don't know if I'm going to have to build this out. I think those players are going to just bring it to me and say, configure it.
Yeah, you're raising an extraordinarily important question, which is there will be a marketplace of capability. No question. Every application known to mankind will have AI in it. The question is, are we getting the right productivity function, the accuracy, the yield of insight per token, and all the rest? And there's a lot of engineering we have not yet uncovered. This is not a mature swipe the credit card and go space. There's a lot of room. You may not be a builder in the sense that you have to physically go and train a model, but you're also not going to just swipe the credit card and configure. There's a lot in between. And let's just take the example of the New York Times story of, I think the headline was something like, that message from your doctor may have been written by AI.
Right.
And it was the story of I think Epic has the inbox assistant tool, very ubiquitous at this point, allow doctors to save time, pajama time, responding to messages by providing an initial draft, right? Pretty safe. It's a draft, it's physician facing. But UC San Diego, who signed on to a group that I've helped organize called healthcareaicommitments.com, their governance process said, you know what? We might have had script tools in the past. We might have built them like a macro, or we might have purchased some. This feels different. We should label and watermark the message, that this message was partially automated and reviewed by your doctor, Dr. Smith. So they chose to watermark. And in the article, basically was like, kudos to UC San Diego for having watermarked. Another signatory, UNC Health, was also named in the article, and they chose not to watermark. They did a governance process, and their judgment was, we don't need to watermark.
Because there's a human in the loop, so it actually is human feedback.
It's the functional equivalent of I used a macro in Excel. Do I have to say I used a macro in developing the spreadsheet? I don't know. That may be a bit far. My point is, it's not a configuration technical thing. It's a governance judgment thing. What will engender trust? How do we want to engage the public, physician users, patients, and others in this journey? And look at the surveys that have come out recently. I think 65% of people surveyed said they want to be told when AI is involved in any aspect of their healthcare. I don't have the exact survey quote in front of me, but something to that effect. There's a lot of work. And even if you ask the question, there's a lot of debate right now. There's a scaling law, throw more compute, more NVIDIA chips, and we just get more and more brilliant models. There's some perception that we're hitting a sort of a scaling limit, and that now it looks like there's other attributes, the algorithms and the software that make all this work, like a reasoning engine, the role of agents to take actions on the systems, where you can have the same model that hasn't really been updated, but you can do all these additional things to make it productive. There's a lot for builders to do and not just configure. So I guess my long-winded comment to you is, my goodness, that room of 14, it would be like in the world of Goldilocks, not too hot, not too cold. No, you're not building the LLM, but you're not just flipping switches and turning knobs and dials. There's a lot of product management that requires thinking, focus, time, and energy. And I don't know if that's the CIO who's going to end up leading that effort. I don't know if it's a chief AI officer or chief medical officer or someone who's doing care delivery reform. Man, but someone's going to have to think about this in a more holistic way, from ethics, reliability, trust, a whole range of subjects.
Captain, our beloved service dog, is back for his third year at Vive and Hims. This Week Health is partnering with Alex's Lemonade Stand Foundation to raise $200,000 this year in 2025. It's easy to participate with this. Snap a photo with Captain, share it on social media, tag us, and for every smiling face in the picture, we'll donate $1 to support these families battling pediatric cancer. A huge thanks to our partners, Parlance, Rackspace, and SureTest for making it possible. Join us and let's make a difference together. Visit thisweekhealth.com to learn more. I'm on record as saying, I believe that Judy Faulkner should have been the CIO of the year for the last 20 years because she has done most of the work for CIOs to make them look good, to roll out new capabilities and make sure that the EHR implementation went well. I think too many CIOs are sitting on that. They're going to take care of me. They're going to make sure. Yes, what you describe happens at just about every health system. A group gets together and says, all right, we need to form governance around this. We need to identify what models we are taking forward. How are we going to engage with our community? Are we going to do a watermark? Are we not going to do a watermark? And yeah, Longhurst and the stuff they've done at UCSD, that's great stuff. And Stanford and Pfeffer, they follow suit and did the watermark. And UNC, it's interesting. I will follow up with UNC to find out like what was the, but I could see that meeting going exactly like I said, where they go, look, I'm reviewing the note. We don't want any note to go out that is not reviewed by a doctor.
Correct.
And we want to communicate to our doctors, don't rely on the note. Like if you don't like it, erase it and start typing again. So
Longhurst did publish that paper. The button has two choices: start over or edit. There's no send.
Oh, interesting.
So Longhurst, and I'm sure others have as well, but I love the transparency of Longhurst. He shows you what he does. By the way, the community we've organized shares that in a portal so that the health systems can work with each other and the health plans. So there's no best practices yet, Bill. We're all learning, but there's an open commitment to collaborate, to say, we tried this. Is this reasonable? It's a little bit, you're trusting to say, how do you do this? Something as simple as an AI inventory, use case inventory, you would think job one of every
That's what they were asking for. That was interesting. The 14 people were saying, look, man, this was great. This meeting was great for me just to hear all the different use cases everybody's doing. And I'm like,
I need the library. And so that question, HHS just published its AI library. The VA did the same. That'd be a fun project, Bill. What are the Indian Health Service AI use cases? And what's the VA? And what's CMS? And let's just consolidate into a master inventory of use cases. And then people can say, okay, I want to run deeper here, try this there, and then ask questions about which one's going to get us the biggest productivity bang for the buck. We desperately need productivity reform. This is the one sector of the economy where we added all this digitization. Back to your data-driven comment, your first question, productivity went down in healthcare. In every other industry, you add technology, productivity goes up. Man, some combination of culture, economic incentives, complexity of the market, productivity went down with digitization. That was a bummer.
So let me use my degree here. My degree is in economics. This is going to be an interesting 4 years. I remember having a conversation with you a while back because there was a change. And I forget, maybe it was from the Obama administration to the next. I forget when we had this conversation.
Yeah.
And one of the things you impressed upon me is that this whole idea of freeing the data and making the data an asset that can work for healthcare is a bipartisan view of how this was going to. I remember having that conversation.
Yes.
Do you still?
Absolutely.
Okay.
In fact, I am in this area. I'm excited. Let's just say we're excited for 3 reasons, right? Excitement number 1. I think we're all excited about Doge. Okay. Let's be clear. Anybody that wants to bring change, if you believe there's opportunity to weed out some historical regulations that don't seem to make sense, you want to champion that. We're going to have a focused effort with presidential support to dig into this. Now, there are a lot of cynics. What's this going to do? How's it going to help? I'm hopeful we're going to see some clearing out the
My, my,
underbrush.
my, my daughter lives in what's referred to as a brothel because there's some law from the 1800s that defines a
Right.
house in this city with
With
three
four or more
women.
girls.
Yeah,
Yeah.
you're just like, what? Anyway,
So these sorts of things, some of that is comedic, but there's also productivity barriers, right? There's a lot of things we can't do because of X, Y, and Z, and we need to have FAQs, guidance. Like, why don't we clean this stuff out? By the way, we had this as an Obama administration priority too. I partnered with Cass Sunstein, who was our head of regulations, back to your economics degree, Office of Information and Regulatory Affairs. Cass wrote the book on how to do this in a more cost-effective way. So we launched it, and we had backing and support, but it wasn't at the scale of the way the Doge is being structured. It's like front center. Anyway, so category one, I'm actually excited about Doge, number one. Number two, for whatever it's worth, RFK Jr. is dedicated to transparency. One way or the other, we're going to have a lot more open information. And you tell me, Bill, how often are adverse events reported to the FDA's adverse events reporting system? It's not in the routine of operations in healthcare. It's if someone was querying, and it just, there's more we can do to increase transparency in the real world adoption and use of therapeutics, as an example. And so I'm excited about a transparency agenda. But again, that was day one Obama. Day one Obama is I want a more open and participatory and collaborative government. Day one. My job was created and introduced to the world in a day one memo on open government, right? But I believe RFK Jr. will bring that philosophy on steroids into HHS. And I think maybe there's a third dimension to this, which is the elephant in the room is we need to bend that cost curve, not just for the employers, but like Medicare needs to address it. We're going to have to pay for the Trump tax cuts in 2025. And the theory of value-based care may not have yet reached the point where it's like a reliable, scorable saver in the budget debate. There may be a window here where this team goes a little bit harder on economic models to bring down the cost curve. It may be more consumer price transparency. It may be more capitated risk programs. It may be embrace MA as the engine to bring some of that capability to market. Maybe different than what a traditional Democratic administration would have prioritized. But I think you're going to see more emphasis on the economic model to drive value in the system. So if you've got open data, you've got a reform mindset, and you've got an economic engine that's powered by the Medicare Innovation Center, one could make a more positive case that in the bubble that is healthcare IT and delivery reform, this will be a pretty active time to be an operator. I'm giving you my best case here.
best case. There's concern. Let's just take Medicaid redetermination and all that stuff. Let's take, you live in Virginia. So there's if certain things don't get funded, I think it's written into the law that essentially a couple 100,000 people or even more than that are just going to drop off the Medicaid rolls. And that's going to be a burden to healthcare providers because they're still going to come in and we're still going to care for them. And so there is, what I'm hearing from the CIO ranks in the meetings is we're concerned that the reimbursement levels are going to go significantly lower. We're already at 1 or 2% operating. And if you go significantly lower, you pull more people off of those rolls. That's going to tip the thing upside down.
Yeah, we have control over our destiny here. So let's just take a minute and maybe frame this conversation in a different way.
I count on you to be the positive one. You seem to be able to find those things.
If you don't have something to look forward to, what do you do with your day? Oh
Right.
man, this sucks. No, we move forward and we work towards. President Obama said very clearly that Washington fights within the 40-yard lines. It seems like, oh, the world's coming to an end and wow, the world's going to be amazing overnight. We're here, okay? The ACA is a Republican idea from Massachusetts, right? With a whole bunch of other stuff baked in. So inside the 40-yard lines. So the issue of Medicaid is the following. I think there's going to be a lot of state experimentation, but there's an opportunity for modernization. So a friend of mine has a startup in medical debt. A health system said, hey, I got this huge backlog of patients with medical debt. And he said, you know what? Let me first find out how many of them actually qualified for our own charity care policy and how many qualified for Medicaid. And of the engagements that they've been, again, email campaign, they didn't just communicate with a few, they communicated to everybody. And for, I don't know, let's just say it's a third engaged. Of the third that engaged, half qualified for Medicaid and we're just sitting there on the bad debt rolls. Half. No change in law. Just we missed it administratively. Half qualified for charity care. If we have a charity care policy, wouldn't we want to administer it? We have rules. Let's make sure that we have the information that we need to hit those rules. Bill, one of my failures, I have many failures. One of my failures is that we built this technical standards in the ACA called Section 1561. The vision was if you're applying for ACA tax credits, you might also want to apply for food stamps, broadband subsidies, etc. How do we share data, either B2B or agency to agency, which is one view, or we came up with an architecture that said, no, it should all be B2C to B. If I apply for tax credits, I should be able to keep with me all those certified data elements, my last year's tax stubs, my immigration stubs, and so forth. Get me all the proof, and then I should be able to bring that with me, vetted, so that I can apply for other things. If I walked into the average hospital's patient financial counseling service, that technology works today for insurance brokers selling ACA plans, web brokers. Is there a single health patient financial counselor at a health system that can do that kind of level of automation? Why?
Yeah, for those who are listening on the podcast, I shook my head no. Why doesn't it exist? The answer I'm going to give is so lame, and it's just going to be busy. There's so many priorities. There's so many things to work on.
But you just told me, CIO said, my goodness, could we lose a point or two or three in total net revenue? And I've just explained to you, the power is in the hands of the CIO to work with financial services to say, wait a minute, I want every single person screened for Medicaid, not just those that have got, if you do the math on it, Bill, hospitals spend so much money after the fact hiring lawyers and teams to go. I remember in Virginia a decade, 15 years ago when I was in state government, I had a state hospital tell me it could be $1,000 per patient to hire someone to go chase them after discharge, get them to fill out the paperwork, get them enrolled, and it's still at a positive ROI because it would move from bad debt to insured. If I can get ACA insurance tax credits in 3 seconds on the internet, why do I have to hire someone to go to someone's house to fill out forms? A and B don't make any sense. So the demand signal for opening up that kind of information so that we can be better about accuracy of insurance status. And by the way, the No Surprises Act gave every American the right to a good faith estimate that has teeth, meaning it's got to be accurate. CMS 4 years later has still not issued the final rule because, quote, the technology doesn't work. Are you kidding me, Bill? We can't generate a good faith. Jiffy Lube gets me a good faith estimate, and woe is me, it's so hard to get a good faith estimate in the US. Give me a break. Focus. Is it a priority? I think this is a moment to say, look, if there's going to be a Balanced Budget Act of 2027, where we're going to slash provider rates by 30% because we're going to have to keep Medicare whole and there's no more subsidies to give, that's not going to be a very pleasant day. Let's work on it now so we have the plumbing and the infrastructure so we can make our way through. And I'm bullish that between DOGE and the RFK, there's going to be a receptive audience on ways we can better collaborate in this sort of thing.
I want to talk about the United Healthcare thing, but before we get there, it's interesting you bring up the billing transparency. And some organizations that I've dealt with did do the work. And there is a tool, or it shows up in their portal, and it's here's the estimate. And I'm like, okay, they did it. And then others just, if I remember, the bare minimum you had to do was to take a spreadsheet or something. Yeah. It didn't even have to be like formatted that well. It just was. I remember downloading a couple of these. I'm like, oh my.
This is not useful.
gosh, I can't make heads or tails. There's 50 things on here that look identical, like they're the same thing, because one gets billed this way to this insurance carrier, one gets billed this way. And so there's no way for the average person to do that. But other health systems did do that work. And I think because they saw it as either part of their mission or part of their service to the community. I'm not sure they saw it as an economic driver of any kind.
In my view, good faith estimates, at least for scheduled services, should reduce consumer-related bad debt.
Yeah, I can see that.
You'll know in advance, and you'll have an understanding of how to make it work. If you ask the average CIO today, or the medical revenue cycle, a lot of that bad debt are from insured patients, where the consumer exposure is high.
Yeah, United Healthcare CEO. It is tragic and definitely not what we want to drive change. But do you think this will have a significant impact on anything? Do you think health systems and providers will start to look at this and say, okay, we've got to do something different? I don't know. I
know Brian Thompson personally, but many friends work directly with him. They call him BT, and everything about him was like family man, good guy, totally one of the team. Like we would get along, and a very good, solid human being. And to my knowledge, there was nothing about him that was the target other than a political statement about the problem. We were going to solve prior authorization automation anyway. Congress is on the verge of passing bills. We've got the prior auth rule. We got AI infused interpretations of evidence-based guidelines. It is already on the path of improvement by reducing friction, not by turning it off. And the sadness that this guy is celebrated in parts of our country, that just tells you we've got an underlying cultural problem that a portion of our neighbors think this is somehow worthy of celebrating. I am saddened. That's what we saw on social media. I'm hopeful and grateful that's probably the small minority of the country that had that reaction. But man, seeing some of those scenes, just heartbreaking.
I wear the hat around that says This Week Health, and so people will stop me and ask me the question, and I'll be like, there's a challenge here, and it's a significant challenge, and it's the opaqueness of this thing. And then all of a sudden it hits you. Oh, my claim has been denied or whatever. And all of a sudden you're now one of the many, and it's still the leading cause of bankruptcy is medical bankruptcy, medical debt bankruptcy in the United States. And so it's getting to the point where we all know somebody who has been impacted in that way. And we're nervous that could be us because we're not really sure how it works. And I was talking to a payer executive, actually a former CEO of one of the Blue Crosses. And he said, the reality is we have a communication problem because our policies clearly state this and this. And then when it doesn't happen that way, it's like clearly stated in there. He goes, but no one reads those things. And then when they don't get it, they're like, hey.
Who's legally allowed to read them, Bill?
Who's legally allowed to read their policy?
Put it this way. Can I delegate it to an app of my choice?
That's a good question.
Under terms of service, it's an unclear question.
Is it really?
Yeah. Medicare Advantage plans are required to be transparent on the rules. But when you go to the website of where those rules are stored, you'll see language that says, effectively, a human can read this, but no third-party app developer can use it or incorporate it into their products. So think about productivity for a minute. Step one, we need an industry consensus on what those words in that evidence-based guideline document mean in code. What's the computable version of those guidelines? There's no consistent industry standard for that. If there was, and presumably would be built on the FHIR data model, an open source data model, then I should be able to run that as a consumer, like a spell check. Okay, the doctor just gave you a good faith estimate, hit the spell check, make sure given the dynamics of the plan you have and the economics and all the rest.
You're describing my number one use case for large language models. I throw information in it and I interrogate.
Are you allowed to?
Let me give you the case. My use case was there's an AI tool that you can essentially make a deep fake of yourself. For good reason, you would do that, right? And so I'm looking at this thing, I'm going, man, before I give up my name, image, and likeness, I want to make sure that I'm not signing away the keys to the kingdom. So I take all the legal documents, I threw it into one of the LLMs, and I started interrogating it. And it essentially said, if you do this, They own your likeness, and they can use your likeness to advertise. They can get you to say, get it to say whatever words they want it to say. And I'm like, oh my gosh, I would have never read all those documents, but it's so much easier. That's the use case. What is the limitation? Why are they not letting us do that?
First of all, we have to ask ourselves basic questions. Why are these regulations, rules, paywalled? And if they're paywalled, how do we make it accessible to those who are allowed to use them in a manner that's productivity generating? So I don't think it takes a lot of work to get people to sit around the room to say, look, what we want is adherence to evidence-based medicine. What we don't want is waste, fraud, and abuse. Check. What we have are EHRs that speak a certain language, and I have claims data coming to me through the Provider Access API 1127. I have clinical data that's in my EHR, the lab results and everything else. I should be able to take a longitudinal patient record sourced from regulated FHIR endpoints and to be able to run that against evidence-based criteria to say, hey, this is what I'm ordering. Does this check? If we could spell check our orders and guidelines and next steps, then would that not move our whole industry towards evidence-based that could lower costs and improve outcomes? And to me, that's the ideal use of AI. It's to generate evidence in the real world. So write the next rule in real time, make it computable and accessible to anybody that has the longitudinal health record so you can understand where you are against it, and then evaluate all the clinical alternatives if there's a problem. A, B, and C. This can be done without a change of law, without a funding stream, without a huge fight over the ACA repeal, not to repeal, this, that, and the other. Just what it would take, Bill, is AHIP and the American Hospital Association sitting in the room and breaking bread on having a mutual agreement as to how we're going to handle clinical decision support on the provider-facing side, consumer-facing side, and prior authorization on payer to provider. If we have a common view that's computational, I think we can make a lot of progress.
This is a little bit of a jump here, but there was the big dust up over the past year where Epic actually shut off access to certain systems who were using data in a way that was deemed not in the best interest of the health system. And one of the, I think one of them was called like Integratort or something like that.
That, man, I'm grateful for Epic for calling out BS on that. That is wrong.
Yeah.
So just, Bill, let's remind our listeners here. What did I say when you asked me about data-driven? Good, bad, and ugly. In the ugly bucket, the highest economic use of data is risk adjustment in the Medicare Advantage program. Like if I had a bit of data on a patient and I had it for any use case across any line of business, its contribution to risk adjustment in the Medicare Advantage population, that segment is where you have a much higher return. It is laughable to say that under the treatment governance of doctors talking to doctors, hey, Bill, you're my physician neighbor, I'm your physician neighbor. In the spirit of goodwill, we're going to make it freely available so that if you see a patient, I'll see a patient, and we're all going to collectively benefit. So we just want the system to work better. Not a really economic model. It's really a neighborly principle. There is an economic model called TEFCA for operations, for quality, risk adjustment, a whole range of things for which there's business interests that are subject to contract negotiation, fees, and all the rest. So what you saw in the Particle Health versus Epic battle is Particle, to be generous, interpreting treatment use as a class action lawsuit firm hires a doctor to look for patients that might have the condition that I don't know, it sounds like lead gen for a malpractice lawsuit to me. Not a lot of treatment happening in that use case. When Epic called them out on this behavior, hallelujah, Epic. Thank you. Because the ugly part of data sharing is if it's only available through this one pipe of my neighborly trust, but it has huge economic value and I'm venture backed, I might feel a lot of pressure to squint my eyes to say, I think of this as legal, but it's not. And they did have a few use cases named that. Integrator made it laughable, but there were also effectively payers looking to source data for purposes of risk adjustments. I'm in value-based care. We need it for value-based care. Is that treatment? Is that operations? What are the economic terms? Is it working? Is that use case live? You could imagine for people who've been trying to do value-based care for a decade, not having access to data is maddening. We desperately need to go from this neighborly trust to a construct like TEFCA that says, here's how we're going to hammer out the use cases and we're going to build. And so we're in the middle of it right now. For your listeners, we need TEFCA for operations and we need to trial it. Mickey at ASTP has been calling it the TEFCA to get 10 payers and providers one by one, point to point. Let's get a few folks to work on the use case of operations. And even before we have this national legal structure, let's demonstrate it's viable in a much more controlled experiment and scale what works. I'm giving you a very long-winded answer to your question.
No, I love that you took it there. TEFCA for operations. It's so interesting because people are like, man, this has taken a long time. But we're at the point now where the frameworks are in place.
Yep.
The mechanisms are in place. The data is probably in the best state that it's ever been. And we have all the pipes, all the contracts and negotiations. We're ready.
We're ready. So what's left is the business model. So if you want Aneesh's little opinion, let's lock down the neighborly treatment to treatment in value-based care contracts where I'm already paid for quality under total cost of care accountability. Call that the umbrella. For those of you who are nerds, HCP land category 3B and above. Let's make that an extension of the neighborly. So we'll do neighborly treatment plus value-based care accountability, and that'll be the first of the operations use cases. And all that should be under the no fee, collaborate, work together, bring down the cost, widen the aperture, opening up the data. That's an agreement we could get done in 2025. We can negotiate those terms, and it would dramatically improve the performance of value-based care contracts.
What's next for you?
I'm grateful for the opportunity to work at Arcadia. We've been friends with the Arcadia team for many years when I was at Care Journey, and we served the same mission objective, which is to advance value-based care through data-driven, to your language, enablement in the pursuit of that high-value care. So we had a lot of shared customers and a very clear alignment of ethics and philosophy. So we came together over the summer. So Care Journey merged with Arcadia to form one chassis for VBC data infrastructure enablement. And I'm grateful to serve as Chief Strategy Officer. I do spend a reasonable amount of time volunteering on public-private partnerships, from Sync for Social Needs to Project Clarity on price transparency to a whole range of veteran interoperability pledge and a whole range of other use cases, the Healthcare AI Commitments Project. I love that. And so we're very much in the spirit of let's rising tide lift all industry boats, not like my vendor machine will beat your vendor machine, but we need the country to succeed. So I love what I'm doing. It's a privilege and I'm grateful for it. And I'm lucky to be a part of a bigger chassis this year than I was last year.
Aneesh, it is always great to catch up with you. And I still consider us kindred spirits, although I don't have my hands on the wheel of the ship anymore, but I'm talking to a lot of people who do. And
you're training them. You're educating them. Your hands are on many wheels indirectly, my friend. That's why we're having so much fun today.
Let's say my hand's on the shoulder of the captain who has their hand on the wheel, and I'm encouraging them in a direction. Hey, I appreciate it. It's great catching up with you, and hopefully you have a great holiday.
You too. Godspeed, my friend. Thank you.
Thanks for listening to this week's Keynote. If you found value, share it with a peer. It's a great chance to discuss and in some cases start a mentoring relationship. One way you can support the show is to subscribe and leave us a rating. Love it if you could do that. Thanks for listening. That's all for now.